Great. Well, hello everybody, and thank you for joining our CCBHC cost report training. I'm Liz Remillard. I'm the CCBHC program lead, and CCBHC stands for Certified Community Behavioral Health Clinic, which I assume many of you already know that as you're joining the training today to hear about how to fill out and complete the cost report. We're joined today by our partners, Mercer and their team, who will walk through the cost report instructions, provide really an in-depth overview of how to complete and fulfill the requirements of the cost report. But before we do that, I'm going to provide a few housekeeping items, as well as an overview of the CCBHC model for those of you who are new, or joining as a partner with your agency from maybe more of the financial end, but want more of that context of why we're doing this model in the first place. So a few housekeeping items. You're all joined on mute, and I appreciate that because it'll help with our recording and keeping the background noise down. However, there will be moments during the training where you can unmute and ask questions. Mercer will have periods of time where they'll open that up and you can verbally ask questions. However, we also will encourage you to use the chat function to document your questions. It's really helpful for us to have logs of those, to be able to provide written feedback if we're not able to answer your questions during our training today. One other housekeeping item that's really valuable for us to also have is who you all are and where you're joining from and how you show up today. Who are you showing up representing? So if you can put your name and your organization, or if you're representing maybe yourself as a consumer or an interested, citizen, please put your name and your role or function, organization really, in the chat. That would be helpful for us for documentation and being able to reach out to you if you have any questions that we need to answer after the training today. So thank you for doing that. Okay, so now I'm going to share a little bit about the CCBHC model, and then we'll jump right into the cost report training itself. So, CCBHC, the Certified Community Health Behavioral Health Clinic model, is intended to coordinate and bring together mental health and substance use services across the lifespan, regardless of anybody's ability to pay for those services and where they live or what diagnoses they have. It's really intended to wrap around anybody who needs care, when they need it and how they need it. We're really excited about implementing this model and being able to really trailblaze and begin to do this in Maine in a way that could support all of you in all the work that you're doing across the state. We're excited to see the interest and the support that we've had from providers in doing this work across the last several years at this point. And the reason why this is so important, and we've been working on this, is that CCBHC has proven to have impacts across the country. We have heard from other states and other clinics from across the country that there have been improvements in workforce retention, workforce recruitment, that there have been impacts to access to care, and that we're able to implement evidence-based practices in ways that maybe we can't do right now in our current form of behavioral health services. So this is it's a really exciting time to be able to work towards implementation of CCBHC, and we really appreciate all of the work that you've all done to get us to this point. This is a really important milestone as we're working on this right now. So at this point, we're nearing the kind of end of the design of CCBHC structure and model. We have a lot of documents that I shared in the calendar invitation with all of you that I'll walk through on a high level today, and Mercer will go through on how to interpret that information that has been shared on the encounters, on the staffing functions, and interpreting those into costs, because that is really where the rubber will hit the road when it comes to implementing the CCBHC model. And as I had mentioned, this is a national model that many other states have implemented and supported and are currently working on implementing and supporting. Maine received a planning grant from the Federal Substance Abuse and Mental Health Services Administration, SAMHSA, back in March of this year. And that was to set us up to participate in what is called the demonstration program, or the demonstration pilot. The demonstration allows the state of Maine to test CCBHC services, to implement and identify ways that we can spread and expand CCBHC across our state, holding up these centers of behavioral health excellence really in our counties, in the communities that we all need. So it's a really, we're working towards our final phase of that planning grant, which is why we're having our cost report training today. As we work towards our timelines for the demonstration implementation, our application is due in March. And so the timelines that we're working towards is completing our cost reports for any interested CCBHC by December 1st to be selected or interested in being selected as a part of our demonstration pursuits. The demonstration grant is a grant, and it is something that we would need to be selected to participate in from SAMHSA and CMS. So any agency that is interested in being a partner with us has that understanding that it's not necessarily a done deal for us either, as we're working towards writing our application and being selected. But we do know that we in Maine have a strong application to be a partner in the demonstration grant. Our goals that we have with our demonstration pursuits, but also just our CCBHC implementation in general, I think resonate with all of you, and I'll go through them right now. We want to design a responsive behavioral health model with CCBHC. We want our providers in our communities to be able to receive the behavioral health services that they need, not just what's available to them because of payment or other infrastructure issues. So CCBHC is meant to be responsive to that and be nimble enough and flexible enough to respond when needed. We also want to use the CCBHC model to strengthen our behavioral health workforce and be able to spread and support coordination between providers as we're working on the implementation of those elements. We know that communication can be hard. We know that can be a challenge as it's not often compensated. The CCBHC model has a foundation of care coordination that we would expect any agency that we certify to do that. And then as I talk about those two elements of being responsive and building out a strong behavioral health workforce, we need to have a sound payment structure for that. That's also tied to quality, and that we can see that quality and the impacts that we're having in our communities. So those are the eye that we have on this for the goals of implementing CCBHC, and would encourage you all to kind of think about how that fits with what you're doing in your CCBHC pursuits as well. So the CCBHC model has a set of 4 elements and criteria that from a federal and national expectations we will need to meet as we certify agencies to be CCBHCs. There are staffing expectations, accessibility and availability expectations, a foundation of care coordination, 9 core services that need to be delivered, based on how we define those, quality reporting expectations, and then governance and accreditation standards as well. CCBHCs are intended to increase access to care, and there is, I think, this simple visual helps to demonstrate what we expect of our CCBHCs when we're working towards the discussions around certification and what we want to see for access to care and services. So as we try to make flexibilities within the service design, this is really where our intentions lie. That there's a preliminary triage and screening for people who are seeking CCBHC services, and if they're in crisis or have urgent needs, that they receive the care and the services that they need immediately or within a day of seeking and requesting care. For people who have routine needs or identified to have routine needs, that they receive access within 10 days of reaching out and requesting services. we're working on, refining and finalizing our encounters plan, as I've shared with you in the calendar invitation. You can pull down that PDF. As we look at the initial assessment, this is really where we're trying to build in those flexibilities so that you as providers can work towards these really ambitious goals of getting people the access to care that they need. Over the last several months, we've held several sessions around our decision-making on the payment and how we're going to pay for CCBHC services. So CCBHC follows a prospective payment system model, which has a cost report tied to encounters and that are compensated for people who have main care. So this is a main care payment model. Try to correct some of these. I'll correct this before I send this out. But Maine has made the proposal and the decision to move forward with a monthly prospective payment system, so that every person who receives a qualifying service within the month, the provider receives the monthly payment. It aligns with a lot of our services that we know and are expecting of CCBHCs to offer. So behavioral health homes, opioid health homes, some of our other value-based payment models. There will be an expectation of quality tied to payment. We'll be sharing more information about that over the next several months, but that is a requirement of the federal model, but also of what we will expect for our main care model as well. One other piece that I think is important to note around the cost reporting as we move forward is that this period of time that we're going to kind of feel like we're, trailblazing into right now isn't the first time that we're going to have, or the last time it's not going to be the last time that we have conversations around cost reporting. We will have more and future conversations with Mercer, as well as with main care team members, to talk about annual cost reporting, or even for those that aren't going to complete their cost report on December 1st, what future opportunities there will be to submit cost reports as a part of our certification processes. So speaking of that, as I talked about our demonstration pursuits, there will be a site selection process that we will share as a part of our demonstration application. There are other CCBHC activities and opportunities that will be shared at a later date related to certification for additional sites that aren't necessarily selected to participate in the demonstration with us. The certification process shouldn't be necessarily new to any of you if you participated in our behavioral health homes model, as we relied heavily on the way that we have rolled out that program in thinking about how we can build off that for our CCBHC certification process. The CCBHC certification will be good for a period of time. At this point, we are proposing 3 years to align with the federal demonstration criteria. And that at every 3-year mark, after an agency is certified, they will have to be recertified to be continue to provide CCBHC services. So this is the end of my slide deck, and I will be passing it over to Mercer to provide context and to run through our cost report for CCBHC. I do want to note that we do have other engagement opportunities. If you're not already engaged with our CCBHC efforts, you can always reach out to our inbox. You can always reach out to myself at the Office of Main Care Services to be connected to either our stakeholder meetings or even request a conversation with our core team at the department. We also have consumer information and feedback sessions led by Mindy Smith at the Office of Behavioral Health. And I would encourage you to share that information with anyone who would be interested in participating in those activities as well. All right, I'm going to introduce John as our partner from Mercer to walk through our cost report.
All right, thank you so much, Liz. Welcome everybody. First of all, thank you for being here today, particularly with everything and the tragic events going on in the state of Maine and in Lewiston, in the community there in particular. We do send, our deepest condolences and, our thoughts and sympathies to you all. And I know, some of you are, probably many of you are kind of helping the effort in terms of, support and supporting that community in particular. So I'd be remiss if I hadn't said that. Again, thank you all for being here. We are excited to put on this training today to help the state advance the CCBHC model moving forward. So in terms of introductions of our team, I am John Villacerta. I am a principal consultant here at Mercer, been here for about 1.5 years. I worked at the state of Michigan prior to that for about 7 years, most recently in their behavioral health administration, where I led the development and implementation of our state's CCBHC demonstration, which launched in October of 2021. I'm joined by a few of my colleagues here today, some of which will be co-presenting, including Toby Ramsdell, who is our sort of the cost report lead for Mercer CCBHC efforts, and also Camilo Merchan, and finally Mike Praniski. And then I know there's others on the call too from the Mercer team, including Pete Liggett and Ashley Selinsky. So I think with that, we can go ahead and move forward, Toby, to the agenda for today. So just going over this very quickly, we're going to talk about the PPS rate background, what it is, what its concept, what its purpose is for, cost reporting principles, provider information, the trial balance reclassifications and adjustments components of the cost report instructions, anticipated cost, visit enumeration, documenting allocations, the PPS2 rate calculation, the certification in terms of certifying the cost report itself and the initial rates that are calculated therein. And then finally, any questions. And then this will be followed by a live Excel walkthrough that Toby will be providing. But essentially, this does reflect the CMS CCBHC cost report instructions and also the CMS CCBHC cost report template. Okay, moving on to the PPS rate background. So really the idea here behind the prospective payment system is to provide a cost-based reimbursement structure, accounting for all historical and anticipated costs that are needed to provide the totality of CCBHC services for all persons who seek care. That includes uninsured, underinsured, people that have, third-party insurance, as well as Medicaid, Medicare, Medicaid, really the totality of that. It mimics the federally qualified health center model of care in terms of the PPS to reimburse for that encounter, effectively a bundle of services, if you will, which we'll get into in a bit in terms of the PPS2 description. Really, I kind of summarize this, but it is meant to sufficiently cover the cost and provide greater financial predictability to providers. And really, I think this is a driving point. It's needed to complement the requisite practice transformation, the care coordination efforts, really all of those facets of care that weren't reimbursable by Medicaid for a very long time. That is a critical component of the CCBHC model, and that is one of the core purposes of the prospective payment system. Next slide. Let's see, what do I want to talk about here? The PPS rate out is paid for each Medicaid qualifying encounter. That's important because even though the PPS rate is derived from total cost divided by total visits, meaning everything, including Medicaid and non-Medicaid, the rate itself is paid out for each Medicaid qualifying visit. The rate reflects cost per visit, and that does include indirect cost allocated to CCBHC services, which we will get into more of in this training. It does not include direct non-CCBHC cost, indirect costs that are not allocable to CCBHC services, or costs that are unallowable under CMS cost reporting principles. The rates are set by state and Medicaid agencies and integrated into MCO rates, but those are not applicable here. Next slide. We talked about this already, so I'm not going to go over this again. So I think we can move on to the next slide. In terms of the PPS-2 methodology, the PPS-2 is a monthly payment rate covering all CCBHC services, which means one patient that receives any number of services, CCBHC services, in a month is counted as 1 month's visit. So it doesn't matter if they have 1 service or 30 services, the 1 service triggers the payment for that month. Under the proposed methodology from CMS, the CMS proposed technical guidance updates to the PPS rate development, they did indicate that the special population rates are quote unquote optional. Under the original rules, they indicated that separate monthly special population rates were needed to reimburse CCBHCs for the costs that are provided to at least 2 or more populations, a standard population and at least 1 quote unquote special population, typically persons with serious mental illness, children with serious emotional disturbance, persons with co-occurring substance use and mental health issues, etc. But in the proposed updated guidance, and this is important for where Maine is heading right now under that proposed guidance, is that the state is seeking to only go with the optional, special population rates component in terms of only using a standard population. So just 1 rate, no special populations, unless the guidance that comes out says otherwise. That said, there is still an outlier threshold and payment process that's required under PPS-2, and what that means is the state must define a threshold for payments that exceed cost within a given month for a given participant or patient. And more to come on that as we'll get into that a little bit more later in the presentation. And then finally, one of the things not on here, but that Liz mentioned, is that the PPS-2 also does require the quality bonus payment process, which has select quality measures that must be achieved before any payments can be distributed under that quality bonus payment methodology. Just a footnote on those optional special population rates, as I had indicated, in what I had mentioned earlier, is that CMS has not finalized that guidance yet as of today. We are hoping that within the coming months, we will see that become finalized. Okay, I think with that, I am turning it over to my colleague Camilo for the next set of slides here.
Thank you, John. Yeah. A little bit of introduction about myself. I'm joined Mercer in March of this year. I'm coming after having worked 5 years at Mass Health, the Medicaid of Massachusetts, in specifically for the Office of Long-Term Services and Supports. So happy to be here with Mercer, and we'll be talking about cost reporting principles for the CCBHC services. So this slide is the basic principles that rule the CCBHC cost reporting. As you can see here, there are 4 that are very important. All of them are important, but going over them are completeness, reasonable and necessary. They should be consistent, and they should follow general accepted accounting principles, GAAP. And very important is that we are going to try to consider only, we're not going to double count expenses. So for that reason is that we want to highlight that they need to be only paid once. This slide is, if you want to get to the report and the instructions that govern the CCBHC general requirements, Medicaid, these are the links to Medicaid to get them. So the next bullet points is CCMS cost reporting general requirements. The report must be prepared on the accrual basis of accounting. All requested information in the CMS CCBHC cost reporting template tabs must be provided, so the information needs to be complete, and all amounts should be rounded to the nearest whole dollar amount. The Code of Federal Regulations governs basically the reporting principles, specifically the 45 Part 75, 42 Part 413, and 2 Part 200. It's very important to remember that the Chapter 45 Part 75 governs the grant and award recipients, and Super E of the Code of the CFR Part 75 provides guidance on general CMS cost reporting principles and specific items. CCBHCs must adhere to these principles when reporting direct, indirect, and unallowable costs in the cost report. So the trial balance basically will capture all of this direct, indirect, and unallowable cost in the report. This chart basically pulls apart the 4 different categories for the cost. The indirect, an example of an indirect cost will be rent and utilities. Direct CCBHC, the cost for the services. The direct non-CCBHC services are costs that have been originated by the center. Like for instance, if there is a hospital that provides CCBHC services, but also provides surgeries, won't be CCBHC costs related. And finally, unallowable costs, an example of that will be bad debt. So it's a cost that will be captured in the trial balance, but it won't be allowed to be included in the calculation of the services. This chart describes the codes that trigger a visit, and that will be used in the encounter reporting by the centers. You can see here that the procedure codes and modifiers again, as I was saying, that trigger an encounter, and that will trigger the number of visits to the center. And this chart breaks apart kind of gives more details on what is a direct cost. So going from bottom to top, the services that we just covered in the previous slides that had a procedure code and modifier are the ones that basically trigger a visit. And those are direct costs, as it's saying in the chart. They're available under PPS. Then we have the support services covered by PPS. So those are costs that are not triggered by the visit. They're not necessarily triggered by the visit, but they have to be included in the calculation. An example of that is care coordination and cultural interpreters. So for these 2 examples that I just gave, you won't see encounters for that, but the cost will be captured in the cost report under the trial balance. And finally, other activities, they might be billable under fee for services, but they are not CCBHC services per se, and they're unallowable to be CCBHC cost. So something that I didn't mention, if you have questions, please feel free to use the chat, raise your hand, and I'll be capturing them so that we can provide you an answer in case something is not clear through the presentation.
All right, thank you for that introduction to the cost reporting principles, Camilo. At this point, I'd like to review the PPS math. So this is the underlying formula that creates the PPS2 rate. So you can see that all direct CCBHC expenses are included in the rate calculation. That'll be in the numerator. Allocated indirect costs, we'll go into indirect cost allocation later. But for now, just know that those costs are allocated. So a portion of those costs that is allocated to the CCBHC is included in the total CCBHC allowable costs. The total CCBHC allowable costs divided by total charges by the CCBHC gives you the cost to charge ratio. And then that cost to charge ratio is used primarily to allocate the total costs between the populations. However, as we discussed earlier, there is no final guidance. We only have that interim guidance from CMS on special populations in PPS2. So at this point, we're assuming that there will be just the standard population. So at this point, the cost to charge ratio is multiplied by total charges, which will give you the total costs of CCBHC services. Again, in this scenario, it will all be allocated to the standard population. Total cost of CCBHC services divided by total monthly visits results in that population's CCBHC cost per visit. So that's the per visit rate. And then that per visit rate times the MEI adjustment. MEI refers to the Medicare Economic Index, which is published by the CMS Office of the Actuary as an inflationary metric, so that we can account for inflation. That is multiplied by the cost per visit, which results in the final PPS2 rate. So before we get into the cost report itself, just know that there are some documents that need to be submitted in kind of a reporting bundle. So along with the cost report, we expect that providers will submit profile information as requested. This may be captured in the cost report as well, but if there are any additional questions, we may need additional documentation as well. Financial statements, these should be the last complete audited financial statements. So for some providers, that may be a calendar year, such as calendar year 2022, or it could be a fiscal year ended 2022 or ended 2023. We would like to request a working trial balance. This will tie the audited financial statements to the trial balance, so we can see the way that the expenses are being reported from the financial reporting system and then transcribed into the trial balance. The audited financial statements, by the way, the total expenses should tie out to the trial balance, specifically column 3, line 53. I'll get into that a little bit later, and we'll walk through some examples of what exactly that means. Allocation descriptions are needed for any allocation used to allocate direct or indirect costs, or any outlier claims as well. Anticipated costs. All anticipated costs, which will be captured in that initial cost report, need to have sufficient supporting documentation. So any allocations or significant assumptions used in developing those costs needs to be reported so that the state can review the way that the providers intend to expand their services. Visit enumeration for visit months and any anticipated visits is needed as well. This can be captured through the EHR, and we'll walk through examples of this. The certification statement, which is required by CMS for rate data, requires a financial officer or someone who is charged with financial governance at the site to sign off on the cost report, stating that it has been reviewed and that the information is complete and accurate. Any DCO agreements that exist are needed to validate that data as well. And then any agreements with cognizant agencies are required. And this may exist if you received a SAMHSA expansion grant or one of those like planning and implementation grants prior to the demonstration entry at the state. So at this point, I'd like to turn it over to my colleague, Mike, who will walk through the cost report structure.
All right, thanks, Toby. My name is Mike Perniski. I've been with Mercer for over 20 years, specializing in financial reporting, specifically with the CCBHC programs. I helped Missouri implement their program, worked with Connecticut as they evaluated a program, currently involved with Maine, obviously, and Minnesota and Kansas and New Jersey to a smaller extent. I'm going to go through a general instructions document of the CCBHC cost report, and then Toby will take it over and actually give a live Excel version of the report. I'm going to go off a video because sometimes when I speak and on video, the lag gets really poor. And so I'm going to drop video. Any questions, please put in the chat. And Toby, if by any chance I can't see them when I'm going through this, please interrupt, and then we can answer those as we're going along. But again, Toby will be going through a live Excel version of the cost report I believe, after the break. So with that, I'm going to stop video. And the first part of the cost report that you'll see is just some general instructions for the CCBHCs and giving some specific provider information detail. You'll report the demographic information of each of your sites potentially, list all providers of CCBHC services, including any DCOs. It will show access, days open, hours open of each of the sites. Part one of the provider information tab is for the main location of the provider organization. And then based upon the number of any satellite locations that your organization has, you will copy part two of the provider information and provide that detail as well for each of the locations. It should be similar to the services provided tab, which is later on in the cost report. But we really want to see the main location, accessibility, hours of operation for all your organizations, all your different locations. I apologize. Moving on, Toby. So the first part of the cost report is really where you're gathering all your cost information. This is historical information as well as adjustments, reclassifications, and anticipated costs. So all that's going to go on one tab of the cost report with supporting schedules for each of the different items. So at first, if you want to scroll down to the instructions, so the top part of that tab is going to be direct CCBHC costs. And these are the costs for the services that are identified on that services list as being actual CCBHC services. So it's the direct provider, hands-on type of costs that are being, those providing the care more or less to the members. The second section of the tab, the trial balance tab, is going to have all your indirect costs. This is the administrative, accounting, legal, facilities, rent. These are the admin costs of the organization that are going to get allocated to the CCBHC program on another tab of the template. And then finally, there's a direct oh, I just saw that my audio's coming and going.
It's crackling a little bit for me, but I can still hear all the words that are coming through. But if that's not the case for other people, please let us know in the chat.
If I talk,
and if not, Mike, maybe you can dial in as opposed to being on the internet chat.
Yeah, let me try that really quick. Hold on.
I can take over for a minute, Mike, if you'd like to.
Sure, go ahead.
All right, no problem. All right, so to quickly summarize while Mike figures out his phone situation, we can go back to the beginning of this slide just so I make sure I capture everything. But direct costs, as we covered earlier, as Camilo mentioned, those are the costs for the services that are identified as CCBHC. So you can reference that state service code list that was shown at the beginning, and we'll show that on the next slide as well. Indirect costs are costs that are shared. You may think of these as overhead costs or facility costs. So that can include reception, accounting, legal, and facility costs, just as some examples. Direct non-CCBHC costs and unallowable costs will be costs for non-CCBHC services. So Camilo provided an example earlier of sites that may perform non-CCBHC services may include, a hospital that has a CCBHC certification, but also would perform surgeries or other general medical services, which would be non-CCBHC services. So I'll show you the proposed scope of services table as well from the state. Again, these are the codes that will trigger direct CCBHC costs. And some of these codes will trigger visits as well. However, some of these codes may be cost only codes, so they may not trigger visits, but the cost is still necessary to be included in the PPS rate, similar to the cultural interpreters example that Camilo mentioned earlier, or those support services. So at this point, I'll show an example of the trial balance. And there's a lot of different columns here. I know it can be kind of lengthy, so I'll just cover some kind of high points first, and then we'll dive deeper throughout the presentation. But first, the first two columns capture compensation and other costs. Now, note that the blue columns are columns that are manually populated. So you as a provider will have to enter in the cost for each specific line in each blue column. However, the gray columns and the gray rows auto-populate. So those are formulas. So columns 1 and 2 automatically sum in column 3. And column 3, line 53 will be the final line in the cost report. That column 3, line 53 should tie to the audited financial statements. So the totality of expenses that were incurred, regardless of the service or activity that they were incurred for, needs to be captured in columns 1 and 2 of the cost report. So column 3 ties to the audited financials. Column 4 is for reclassifications, which generally pertain to some kind of allocation or any necessary adjustments that need to be made to a specific line item. I see that Mike is back on the phone. So Mike, if you'd like to jump in and continue from reclassifications through the rest of the trial balance, go ahead.
All right, you can't hear me, please let me know. Does that sound better, Toby?
You sound good to me.
Okay. So as Toby had mentioned, so once column 3 totals the audited financial statements, on the reclassifications, we're really looking at moving items in between line items. One of the examples is, say, your psychiatrist is also performing some administrative functions of the organization. All the initial expenses could be listed in the psychiatrist line item 1, but if, say, 20% of his or her salary is providing administrative functions, you would want to move 20% of that person's salary from line 1 to an administrative function in the indirect cost section. So this whole column is really moving items around. The total of reclassifications should equal 0. That is going to be a critical check because there is a reclassifications tab, but that tab does not automatically roll forward to the trial balance tab. So one of your checks will be to make sure all reclassifications equal 0. So once you've performed those reclassifications, given that everything zeroes out, line 5 should also tie to the audited financial statements in total, given that nothing has been added or taken away, just moving from item to item. On that item of line 5, we then come to adjustments. Adjustments are going to either be increases or decreases based upon cost reporting principles of CMS. So as was mentioned previously, some items are unallowable, so they won't be included in the cost report. And there's a specific tab that we'll get to later for specific adjustments. But on that, you would have the ability to have increases or decreases. So given that this does not necessarily equal 0, the adjusted column 7 will not have to tie to the audit financial statements. And again, we'll get to more specifics within each of these columns when we go to their specific tabs. This is just a general overview of the trial balance. And then finally, any adjustments for anticipated costs. So to the extent you need to add services to perform all the CCBHC functions, this is the column where those costs are going to be added. So once you perform your assessment, you'll determine what costs and services need to be included and added to meet the CCBHC program. There's a specific tab for this column as well. This is one of the items where a lot of detail will need to be provided to the extent you're adding specific staff, would like to see some staffing assumptions, members per person. Those types of things are going to support the anticipated charges cost to really give us a better understanding when we review the cost report that, yeah, you understand the program, the adjustments for anticipated costs make sense, and as we go through the approval process, that's where we're going to look at that. So that's the direct tab of the trial balance tab. If you want to scroll down to the next slide. So this is the component of if you have any DCO arrangements. The DCO arrangement is going to really be contracted costs that the CCBHC program has with a DCO directly. To the extent none of those are in the current audited financial statements, these could just be all in the adjustments for anticipated costs. So these are those organizations that you're going to contract with that are going to provide some CCBHC services directly on the organization's behalf. So to the extent those currently aren't in the financial statements, they would mainly be adjustments for anticipated cost changes. And if that is the case, there additional detail will need to be provided versus just a dollar amount. If it's contracted rates, if it's what your, what services are going to be provided by the DCO and what the contract is for that specific service. So to the extent you have DCOs that you're under contract with, this is where that information is going to go. Next slide, please. So in essence, column 1 and 2, as we had mentioned, total to the audit financial statements. This is going to include direct CCBHC, the indirect costs, direct non-CCBHC. Column 4 and 6 are used for reclassifying and making adjustments. Column 4 is going to be zeroed out at the bottom, as we had mentioned, moving from one line to another. Column 6 is going to be increases or decreases for some items that we'll get to in a little bit. And then finally, column 8 is for anticipated costs. They're allowed in the initial cost reporting submission, given that you're having to build up your potential services array and what you offer to meet the CCBHC program. These are not included in the audit financial statements, and any detail for such costs and visits, as we had mentioned, will need to be clearly laid out and detailed so we can gather an understanding for the reasonableness of those costs and services. Next tab, please. This is, up above, when we first went to the trial balance tab, we were talking about the direct costs. So this section is specific for the indirect costs of the CCBHC. You could see rent, insurance, utilities, depreciation, office salaries, pretty much just administrative functions of the CCBHC program. So this information is going to, you know, in total, once you get to all your adjustments and reclassifications, and to the extent you need to make adjustments for anticipated costs in the administrative or indirect side of the program, that total at the bottom here is what is going to get allocated to the CCBHC direct costs and be included in your PPS rate. So to the extent whatever portion of indirect costs is related to the direct costs of the CCBHC program get added. And we'll go through the options for that later on when we get to the actual indirect cost tab. But for now, that is all the indirect costs of the program. When we were talking about reclassifications and adjustments, again, reclassifications are for shared resources that would maybe go between direct, indirect, and direct non-CCBHC services. Any allocations that get added and subtracted in different rows and columns are going to need to have an explanation on the actual allocation, on the actual reclassification tab. As we had mentioned, these should net to zero. Any adjustments are going in that other column that we're going to talk about in a minute. Common adjustments are things such as related party transactions. If there's any lobbying, you know, as mentioned earlier, bad debt expenses, those types of costs that are not reimbursable under CMS cost reporting principles. So those are the ones that are going to be adjusted out. Moving down, okay. So the first tab, trial balance reclassification. Again, this is to move expenses between line items and sections. Appropriate allocation methodologies could be a percentage of time that, say, in that example, the psychiatrist spends between direct services and administrative functions. If you're moving in between CCBHC direct and non-CCBHC direct, total revenue could be an option for moving items in between those categories. And the person filling out this tab has to remember you have to move that information from this tab to the actual trial balance tab. Every decrease from one line item has a corresponding increase to another line item. And that's where, given this is not automatic, you'll have to verify that on the trial balance tab, everything equals zero. Then again, as we had mentioned, on the adjustments tab, it's to eliminate unallowable costs following CMS cost principles. So there's specific categories on this tab. So you could see the top one, investment income on commingled or restricted and unrestricted funds. You have rebates and refunds of expenses, home office costs, depreciations. So there's specific items on those links at the beginning that have CMS cost reporting principles. So to the extent, you know, you read through that and say, okay, I need to make an adjustment on my expenses, this is really where they're going to go. So this one also allows, can you go to the next tab, please? Okay, can you go one more? And then we'll go back a second. Okay, so part one had additional adjustments. Now part two is those items like bad debt expense, charitable contributions, fundraising costs, goodwill, lobbying. these items are definitely not allowable. So anything here is going to really be a negative adjustment, a decrease to your allowable costs. So going back up now, I just want to show the two together. Okay. So within that, you will have to provide detail on your basis for any adjustments. And to the extent that, okay, this item here, adjustments for known changes from the reporting period to today. For example, if your last audit was sometime in 22, and that has to tie to your actual trial balance column 3, that since that point in time, you have made substantial adjustments in your financial situations during 2023. For instance, maybe you had to give a salary increase that wasn't necessarily included in 2022. Anything to move from your audited time period to today that you feel isn't justly captured in the audited financial statements can be included here as an increase or decrease if, say you had a substantial staffing change. But to the extent there are charges in your financial statements that aren't accurately reflective of where you're operating today since your last audit period, you can provide that increase here in column like 11A and have a lot of detail to what adjustments are being made. So that's when we're talking about adjustments for known changes from the reporting period to today. That is what is being referenced, where your most recent audit financial statements isn't an accurate reflection of the reporting of cost at this point in time when you're filling out your cost report. Do you have anything to add to that, Toby?
All I would add is that, for any adjustment, there needs to be significant documentation. So everything must be very well documented when you're making, assumptions for reclassifications for adjustments. So make sure that supporting documentation is very robust and easy to understand.
All right. And one other item that comes up a lot is grants. How is grants being, to the extent the provider has grants coming in, how are those to be handled? And so within this PowerPoint, when you're filling out your cost report, please review this and ask any clarifying questions that you may have. But we have some general guidance here on how to handle grants. And the first item, I'm just going to read it. For exclusive non-CCBHC grants, or if all of the grant revenue is for uninsured or underinsured, or if grant revenue is from CARES Act funding or non-recurring funding service, do not offset any expenses. So you will not make any adjustment in the cost report for these situations. And the reason is, if you offset expenses, it's going to affect your indirect cost allocation. So for these situations, really don't do anything. Now we come to, for CCBHC services and intended for all recipients, including Medicaid, and if the grant is recurring, you would offset the applicable expenses that that grant was funding for. And what this will do in the end is reduce your PPS rate. And the reason that that needs to occur is the CCBHC grant or funding process can only pay for services once. And so to the extent that you're receiving grant money for those services, and if you included those in the actual cost report, you would also receive CCBHC funding for that same service. And so that's where this guidance comes in. That's going to reduce your PPS rate, so that way you do not get, I'd say, double funding for the same expense. That is the general grant grant discussion. And so those would be included as an adjustment, you know, to the extent you have grants that you need to adjust, that would be an adjustment in that column that was just up on the screen. And so, like a historical data summary. So we want you to account for all expenses from the last audit. So that goes in columns 1 and 2. And once you get all those expenses, you're going to bucket those costs as direct CCBHC, direct non-CCBHC, indirect costs, and then you'll make those adjustments for anything that's unallowable. Reclassification, all need to be documented. Adjustments need to be well documented and describe how you get from, especially if you're adding costs from your last audit to your current reporting period, you need to provide a lot of detail on why and how you're going from audit to now, what is substantially different, and what's the support for those differences. In general, are there any specific questions? Toby, I know you've been getting a lot on the chat that I haven't been looking at, but is there anything we need to address?
So we've been covering all questions in the chat that have come in. Right now, we're a little behind time, I think, so let's keep pushing forward. For now. We can stop for some questions at the end if there's any questions that we want to take live right before the break.
Sounds good. Okay, anticipated costs, we've mentioned that's the last column in the trial balance tab. You want to move down. Anticipated costs are for the expansions of services to meet the CCBHC requirements and any other planned service offering increases. The costs, you add costs for recurring expenses incurred since the last audit, but prior to the demonstration period. So these are the costs you want to add to meet the CCBHC program. Do not adjust for anything for inflation. We have an MEI adjustment in the cost report that is going to account for that. And note that you want to annualize anything that's less than complete data. So we want to get an annual rate. Given the PPS rate is for a whole year period, we need to get the total cost of that period. To the extent you're annualizing expenditures, you need to also annualize any increase in visits. And so not only are you going to add anticipated costs, but in the visit section, you're going to add anticipated visits. And these will be tested for reasonableness just to make sure any added costs, you know, divided by your added visits makes sense compared to historical and makes sense comparative to the actual services you're having to expand on. So that's the anticipated cost section. This is where I turn back over to you, Toby.
That's right. All right, thanks, Mike.
Right.
So Mike got us through the cost part of the cost report. So now what we're going to walk through is how to document and record visits in the cost report. So quick reminder, I know it was a while ago in the presentation, but the state has chosen PPS2, so we'll be identifying monthly visits. So I think what's key here is that the first thing to do when you start is to pull data from the EHR. So identify patients receiving CCBHC services. So that would be any patient that received any CCBHC service during the reporting period. That includes DCO services. So I'll point it out to you on the next tab, but the monthly visit schedule has spaces for DCO services. Then what you should do when you're enumerating these visits is identify months when CCBHC services were provided. So these are by patient, by month. Reminder that multiple visits in 1 month will count as 1 visit per patient. And then DCO CCBHC services, that data should be collected directly from the DCO. So that needs to be a part of the agreement to share that information, as well as the cost information that's reported on the cost report. Do not count the same patient, same month services multiple times. I think that's really the key point that we want to hammer home is 1 patient visit per month, regardless of the number of services provided. So at this point, before I get into the content, I just want to disclose again that Maine is following proposed CMS guidance at this point. So the proposed CMS guidance is that special populations will be optional. So at this point, you'll see that there are spaces for certain special populations, but today in this presentation, we will not be covering special population visit enumeration or criteria. If this is needed, we will provide that technical assistance at a later date, but we're waiting on the final word from CMS there. So you can see that historical monthly visits, those will be the monthly visits that were actually occurred during the cost reporting period, are reported on line 2. DCO arrangements, which should be reported fully and timely, are reported on line 3. Anticipated monthly visits for new staff, new services, or additional capacity, and again, that'll be part of the initial cost report, should be reported on line 4. Again, Mike got at this earlier, but I just want to reiterate, anticipated visits should be occurring for any anticipated staffing increases or an expansion of services. So make sure that you're documenting anticipated costs and anticipated visits very well. Now, there's a component of the PPS2 rate that's required, which is the outlier threshold. So you can see that's column 1B on this slide up. So visits above the outlier threshold are patient months with costs exceeding the state-defined outlier threshold. We'll cover this in more detail on the next slide, but I also want to reiterate that at this point, there is no outlier threshold that has been definitively decided on by the state. So again, additional information will be forthcoming from the state on the outlier threshold. However, we'll still be able to walk you through some pretty simple ways to get an idea of which patient months may exceed the outlier threshold. And then I want to emphasize that there is a services provided schedule. We'll cover that later, but the services provided should be more than the monthly visits. And the reason for that is, even a single visit can have more than 1 service provided. And that is just expanded by the fact that, an average patient visit month may include more than 1 visit. So per patient visit, multiple services are likely to be provided. So that can be kind of confusing, but just make sure that that's reasonable and that follows that description. All right, so here's a very quick overview of outlier visit identification. Here's a method that I've used and I've prepared to identify outlier costs. So one method that you can use to identify outlier visits, which would be, again, those patients that experienced those costs that exceed the outlier threshold, you can look at the number of visits in a month and kind of, ballpark by seeing the number of visits in a month. Is this patient likely to have had a high cost visit month? And would that be likely to trigger the outlier payment threshold being crossed? So you can see these first 3 columns are EHR data. This is all sample data, but in this data set, those first 3 columns represent the claim number, the patient identifier, and the date of service. From that point, what I've done is I've created calculated fields. So I built out a formula to look at patient and month combinations for each visit. And then I want to analyze unique patient months. So what this does is it ignores duplicate patient visits in a month, because we only want to count each patient visit in a month once, so that there's no, I don't want to count, 2 visits for a certain patient as 2 visits if those occur in the same month. So that's the reason for looking at unique patient months. Then you can search the date of service provided and the month of service provided to see the number of times that a patient had a claim or an encounter in a month. So that's different from the number of visits, which would be 1. But that would show you, how many times the patient came into the CCBHC and received services in that month. Then from that point, what I did in this example is I identified the mean and the standard deviation of the data set. So seeing, what is the average number of times a patient came in and received services in a month, and then what is the standard deviation of that? So how far away is the average value from the mean? Typically in statistics, an outlier is considered 3 deviations from the mean. So I've identified some claims strata. So in this case, anything over 12 visits in a month, or 12 encounters, still counted as 1 visit, but 12 patient encounters at the CCBHC for the same patient would be beyond 3 standard deviations from the mean. So that is how I identified outliers or potential outliers in my data set. So you can see I have an example of a patient that had 12 claims in a month, which I've identified as an outlier. This is just one of the techniques that you can use to determine which claims may be outliers in the data set. There's also, if you're able to use your EHR and track specific claim amounts to a specific visit and look at those total claim amounts for a month, you can kind of use a ratio of average claims to cost to be able to determine outliers as well. So this is not the only approach. And we'll be able to provide additional technical assistance on this, since I know that this is kind of a complex topic. But this is just an introduction to, how to use some statistics to determine which claims may be outliers in a visit data set. All right, so from the prior exhibit, I was able to put those numbers into the cost report. So I identified 1,019 unique claims and 12 claims that were likely to exceed the outlier threshold. Note that these 12 claims that exceed the outlier threshold are actually a subset of the 1,019 unique patient month visits. So the total visits I think what's key to understand is that the outlier population is a portion of all visits. So those numbers, the outlier population is like a subset of total visits. You would record any DCO. In this example, I had no DCO visits. And then you would also record the number of anticipated visits. So in this example, I used an assumption of a 30% increase in visits. When you're actually preparing your cost report, you should be able to document anticipated visits. So a blanket, 30% increase in visits wouldn't be acceptable documentation. But for this example, I wanted to show you how anticipated visits would be recorded for the visits from that data set. All right. So moving on to documenting allocations, there's a tab in the cost report called allocation descriptions, where you can allocate any allocation, or you can document any allocations that are made. You may also choose to record and document allocations in supplemental schedules, which is perfectly acceptable as well. So common allocations occur for payroll and benefits, because you may have personnel that work as in each part of the CCBHC and through business structure. So you may have providers that bill direct CCBHC costs. Those provide those direct CCBHC services. They may also provide non-CCBHC services that are reimbursed in some other way. And those personnel may also provide, indirect costs. They may be a part of management or provide some administrative functions. So in that case, you would need to allocate part of their time from direct CCBHC to indirect costs, or direct CCBHC to non-CCBHC direct costs. All right, and then finally, allocation should be consistently applied. So whatever methodology is used to allocate time should be used for all practitioners. It would just get too complex if you're picking and choosing and combining methodologies. So to keep things simple and consistent, make sure that the principles are consistently applied. The same allocation methodology should be used across positions. All right, an important allocation is indirect cost allocation. So there should be a description, again, for any allocations that are made, either in the allocation description schedule or in supplemental documentation. However, there's also a separate schedule for indirect cost allocation in the cost report. There are really three primary ways to allocate indirect costs, and then a fourth method available. So the three primary methods are cognizant agency agreements, which we covered earlier, but those have to be used if you have one. There's the 10% de minimis rate, so that's the federal minimum, and that may be used if the CCBHC has less than $35 million in revenue from CMS. And then the final primary and probably the most common indirect cost allocation method that we've seen is a percentage of direct CCBHC costs to total direct costs. A fourth method is available, which is another method of the provider's choice, which would be described in detail either in supplemental schedules or in the allocation descriptions tab. So in this example, hypothetically, you could use indirect personnel costs allocated by revenue, but facility costs allocated by square footage. Any indirect cost allocation must be well documented, but if the fourth option is chosen, the documentation must be, particularly robust and well documented. And the state has discretion on acceptance of those additional methods that are prescribed outside of the cost report and determined by the provider. So just consider those when you're choosing, or if you have a choice, unless you have a cognizant rate agreement, but just consider all of those implications when reviewing the indirect cost allocation schedule. All right, so to the final part of the cost report, the PPS2 rate. Most of this schedule automatically populates. Again, a lot of gray cells here, which are formula driven. What providers need to do is enter charges for each population. Again, we're assuming only a standard population at this time, but enter charges for each population on lines 1 and 2. So line 1 will be for actual charges and line 2 will be for anticipated charges. Again, anticipated charges should align relatively and reasonably with anticipated costs and anticipated visits. Again, going back to the PPS math, the cost to charge ratio is used to allocate costs based on the charges between those populations, but we're assuming only a standard population. However, the standard population outlier charges should also be identified using a similar methodology that was used to identify outlier visits. So that's column 1B. And again, those outlier costs are a subset of all charges in that standard population. So part 1A. All right, then the second part of the PPS2 schedule is kind of the rate breakdown. So for the standard population, all that needs to be, for all populations, really what needs to be entered is the Medicare Economic Index figure on line 12. So I will show you how to calculate that in a minute, but all that needs to be entered on the PPS2 rate schedule are the charge information and the Medicare Economic Index factor. And then the rates will automatically calculate, and the outlier pools, which will be the amount over the outlier threshold, will be automatically calculated. So for cost report principles for the rate calculation for PPS2, again, note that it's direct CCBHC as we've shown, allocated indirect based on that indirect cost methodology chosen equals total allowable CCBHC costs. Divided by total charges, that gives you the cost to charge ratio. Then for each population, again, we're assuming only a standard population in this case at this time. The cost to charge ratio is multiplied by total charges for that population, which is the total cost of CCBHC services. When that figure is divided by total monthly visit, that is the unadjusted PPS rate or the cost per visit. And then to adjust that PPS rate to the final rate, the MEI trend is applied. So that is how the PPS math breaks down. All right, let's talk about the Medicare Economic Index. This is pretty straightforward. It's just some very simple math, but you can obtain a copy of the Medicare Economic Index from the Office of the Actuary at CMS. So the link is up here and provided for you. The way that you determine the Medicare Economic Index, and by the way, the factor that we use is the 2017 based Medicare Economic Index. So that is the factor. But the methodology uses determining the midpoint of the reporting period. So that'll be the midpoint of your audited financials. And then determining the midpoint of the rate year. So, you know, in that case, we would look at the year that you're certifying your rate for. Then you divide the midpoint of the rate year factor by the midpoint of the reporting period factor. So you can see in this example, I've taken my reporting period is 2021 Q4 and my rate period is 2023 Q4. So I got the factor from the market basket published by CMS. And I just divide the rate year factor by the reporting period factor. And that gives me a trend, an MEI trend of 8.64%. So that will be the adjustment to the unadjusted PPS rate or the cost per visit to cover the cost of inflation. So this math is not very complicated. You know, using exponents or any, you know, weighting factors or crazy factors like that is not required. But if you have any questions, of course, please feel free to ask them. I know that this can be a little challenging sometimes as well. Finally, we're going to discuss the certification. So here's the full certification statement from the cost report that a financial officer or someone who's charged with governance over financial reporting is required to sign. So that should be signed, fully populated, all fields. That is included in the cost report as well. And one thing that is, I think, helps ensure that it's always received and completely filled out is if that document is printed, signed, and scanned and included in the cost report bundle. So included in that whole reporting package that includes the cost report and supporting documentation. All right, we are right on cue at about 12:30. Sorry, I'm in Central Time. So here are questions. This is the email for the main CCBHC mailbox and for their inbox. So send your questions there. But if there are any questions right now, we can probably take, 5 or 10 minutes and answer some questions live, or you can put them in the chat. Feel free to come off mute if you'd like as well. Well, all right, if there's no questions coming through, you can continue to put questions in the chat if anything, comes to mind. And of course, there's still another half of the presentation left. So quickly, we're going to take about a 15-minute break. We'll resume at 12:45. But yeah, please feel free to leave questions in the chat if you think of anything. I see we might have gotten one right now. Given that inflation has been so high, does that inflation lag and will it impact the rate? You know, there is a little bit of lag, of course, but the Office of the Actuary has been very precise recently in releasing those updates about quarterly. So the last market basket update was published in late September. So that information and those indexes are very current. So that considers, you know, how inflation has been pretty significant recently. But that's a great question. Well, all right. Like I was saying, please continue to put those questions in the chat. We can pick them up on the other side when we continue the presentation, but for now, let's take a 15-minute break and come back at 12:45 to walk through a cost report demonstration in Excel. All right, it's 12:45. Let's pick it up again. Let's go through an Excel walkthrough of the cost report. I hope you can all see my screen. Please let me know if there's any issues with the screen share or anything like that in the chat. And then please continue to put questions in the chat, which we'll be happy to answer either, you know, throughout the rest of this live demo, or we'll make sure to answer any unanswered questions at the end of this session. And please feel free to use that state email address as well, that mailbox for the CCBHCs, to make sure that all your questions that you have that might arise, you know, after this session, or if there's anything as you're looking through the cost report or instructions, you know, please feel free to send those out as well. And we'll make sure all your answers get questioned, or all your questions get answered. All right. So where we're going to pick up right now is in the sample cost reports, and we'll start off with the certification schedule. So the certification schedule I populated with, you know, dummy information, but this is an example of that language again, and the signature of the officer, who is a CFO in this case. So again, someone who is, you know, overseeing the financial reporting process needs to attest to the cost report. And then that cost reporting period needs to be captured as well. So all that information is complete. All right. So now we're going to walk through a couple supporting documentation slides. And so these tabs that we're going to walk through, you're not going to find them in the cost report, but I'll let you know when we get back to the cost report. But just keep that in mind. I'll make sure to point it out. So this is a sample billing code list. I just want you to take this with a grain of salt. This may not accurately reflect the state's proposed billing code list or that scope of services table. But for our purposes for this presentation, this is a sample of, you know, CCBHC type services. And again, I'll be using this dummy service code list to determine direct CCBHC services from, you know, the services that are included in the visit example that I'm going to walk through. So the first thing that I want to do is address visit enumeration. We walked through some outlier visit enumeration. I'll show you that again, maybe in a little less detail this time, but I also want to walk through, how do you determine standard population visits? So let's take a look at that next. So for standard visit enumeration, what we'll be looking for is there a service code that triggers a CCBHC service? And so in looking at this, I've got some sample EHR data. That's what my light blue fields are. This is sample EHR data. So, when you're preparing your cost reports and you're enumerating your visits, you'll want to make sure that your EHR data has some general fields, such as, the patient ID, member ID, service date, procedure codes, the description of the service. And then you'll have to do some calculated fields as well. So those calculated fields that you'll want to reference, you'll want to count if it's a CCBHC service or a non-CCBHC service. So that's what's going on in column F. Column G counts if that CCBHC code that's in column D triggers a visit or not. Remember, some CCBHC codes are cost-only codes. So we'll want to make sure that only visits or only services, only codes that trigger a visit are actually counted as visits. And then what I've done is I've created a modified service date. So since we're using PPS2, I don't really care much about which day of the month the service was provided. I really only care, which month the service was provided. So I can count, the number of times in a month, for example, a person received a service, but I can also identify unique months where a patient received services. So in this case, in column H, you can see, okay, a CCBHC triggering service, a visit was triggered for community support. So that occurred in March 2022. Then for the same patient in the same month in March, day treatment and community support were both provided. So these are also CCBHC triggering visits, but they'll only be counted once because they also occurred in March. Then you have a CCBHC service provided in April and then again in May for the same patient. So because I have a visit in March, April, and May, I should see, 3 visits for this patient. All right. We have another patient who receives CCBHC services as well. Again, all of these services received. You have multiple visits in April, all triggering CCBHC. Well, 2 of them trigger, sorry, but all of them are included in cost. And then 1 emergency department visit, which will not trigger a cost or a visit. So in this case, for this patient, we should only see 1 triggering visit. So I should have 4 triggering visits. And so that's what I've done over here. is I've enumerated the number of visits, the count of visits based on the member ID and the modified service date. So what I'm doing is I'm parsing the data to identify which months did a member receive a visit triggering CCBHC service. And then I'm only counting 1 visit per month. So for the month of March, this patient 1, 2, 3, 4, 5, 6 with that patient ID will receive 1 CCBHC visit, despite the fact that multiple triggering visits or multiple triggering services were actually occurred in that month. So multiple visits in 1 month equals 1 visit for the purpose of the PPS rate enumeration. So that's a strategy that you can use to kind of translate your EHR data into the visit data to populate the CCBHC cost report. Again, make sure all the visit enumeration is very well documented. This is an area where, from my experience, I've had to do a lot of back and forth with providers on how they enumerated their visits. So in order to quickly, review and accept cost reports, I recommend making sure that documentation is very thorough. So, Here's the outlier visit enumeration example again. And so let's just do a quick overview. I know we walked through this at length earlier, but essentially what I did is I took EHR data, translated it into a unique ID that captures both the patient and the month. That's the way that I'd recommend identifying, patient months. And then I went and used a formula to determine which patient months are unique. So I only want to count each patient month once. From there, I could look into my total patient and month IDs and then look at my unique IDs to see how many times did the unique ID occur in the total data set. So in this example, 4 times. And then from that point, I place the visits into a visit stratification. And that's based on standard deviation, as I mentioned before. So the way that I approach outlier visits in this example is by using standard deviation to look at, which patient months, which unique patient months had over 12 visits in a month. And then, as I showed you in the PowerPoint walkthrough, you can enumerate visits based on this data. So counting my unique patient months, I know I have 1,019 unique patient visits based on these unique patient months. So that will be my standard population visits. Then I can look at my outlier claims stratification and see that I had 11 plus 1 claims that were over 12 claims in a month. So that's the unique patient months where the patient had over 12 encounters at the CCBHC. So I should have 12 visits over the outlier threshold. And I can see that that's the case here. So I've reported my 1,019 visits as the standard population, which includes all visits for that population. Then for the visits above the outlier threshold, I can go back to my outlier visit enumeration and identify 12 total visits exceeding 12 encounters per patient per month. You'll see again in this column that 1,019 is the total visits because the 12 outlier visits are a subset of the standard population, all visits. I reported no DCO visits in this example. I wanted to keep things relatively straightforward, but again, make sure that that data is collected from the DCO. So that data sharing needs to be clearly understood between both the provider and the DCO in crafting that agreement. And then for the anticipated visits, again, what I did here is let's say that I plan to, hire additional staff, 30% additional staff. So I want to hire, increase my staffing by 30%, my direct service staff. In this case, I've anticipated 30% more visits. So that's an example of how anticipated staffing levels may relate to anticipated visits. Again, in an actual cost report, I would make sure that I can provide actual hard numbers and a reasonable basis for needing that additional staff as supporting documentation as well. But this just shows you how the visits sum to the total patient months. So that total amount is 1,325 based on this example. What if the same client is seen by both the DCO and the CCBHC? I think that that is a great question. And to my understanding, John, please feel free to chip in. But if the same client is seen in the same month by both the DCO and the CCBHC, that would still just be one visit. So that patient information, it may need to be de-identified PHI of some sort, but based on using the same patient data, there may be a way to identify if that's the case. But John, do you have any additional thoughts on that?
Okay, this is Mike. I'm going to agree with what you had said, that there would only be one payment per month per member, even if they were seen in the DCO and the actual CCBHC. There has to be a way that would just be counted as one.
Okay. All
Yeah.
right, thanks, Mike.
I was just going to say, sorry about that. I don't think you could hear me. I agree with what Mike just said, and I agree with you, Toby. I think for the purposes of the visit, yes. However, each discrete service that is provided by the DCO on behalf of the CCBHC should still be paid per their agreement that they have in place.
Yes, that's right. That's a great point. So one visit will be counted, but the CCBHC will still have to pay out the agreed upon rate to the DCO for that visit.
And is it okay for me to offer a clarification here about?
Absolutely, Liz.
Okay. Don't want to mess up the flow of the training. When we are talking about DCOs in the context of the cost report, we are talking about any encounterable service can be DCO'd financially and have a financial partnership with another provider to offer a service through your CCBHC or for your CCBHC clients, except for crisis financially. So mobile crisis, we are expecting a non-financial DCO, which means that we are expecting a partnership between any provider that does not offer mobile crisis services. However, the cost reporting does not apply to that, to the encounters that the other crisis provider offers to a person that may be within your CCBHC. So, and if you are a crisis provider, those encounters do not apply to the visits, nor do they apply to the cost. So I think that's just a really important element to call out right here while we're talking about DCOs. Mobile crisis services. We can offer some more clarification in writing after this, but I just wanted to say that out loud.
Thank you for that additional context. All right, so having gone through visit enumeration, let's move on to the cost report itself. So moving on to the services provided schedule, I think Mike talked about this earlier. I think what's key to point out here again, and just reiterate what we talked about in the deck that we showed earlier, is that the total number of services is going to exceed the number of monthly visits. Again, that's because a patient may receive more than one service per encounter, as well as the fact that, you know, a patient may be seen 2, 3, 4, even more times, even up to, you know, I guess as many days as there are in that month if needed. So the number of services provided will be greater than the number of monthly visits. This schedule just reports the number of services and the number of full-time equivalent staff. So really what this is useful for is just kind of gauging metrics. These numbers don't affect the PPS math at all, but it's very helpful for the state and for its reviewers to understand average cost per service, for example, which you can see in column 4, which kind of gives an idea of, you know, efficiency metrics. And another thing that we like to use the FTE data for is to examine, you know, salary per FTE and other supplemental metrics. So while this schedule does not directly impact the PPS rate paid, it does provide insight into, you know, the operations of the CCBHCs and should still be, you know, considered essential to completion of the cost report. All right. So this is actually the beginning of the cost report. The services provided schedule kind of comes later, but we wanted to show that in relation to the way that the visit enumeration schedule works. So those are kind of related in terms of the visit per provider. But the provider information schedule is the first schedule that you'll probably fill out in the cost report, which just contains general information for the sites. So if you have a single site, you'll only fill out the provider information schedule, this top part. This contains, you know, identifying information. So the Medicaid and NPI should be populated. Street name, you know, the name of the clinic, city, state, zip code, county, basic information like that, as well as the organizational authorities such as nonprofit, and the location designation. You should also insert lines for behavioral health professionals, which should roughly align with the services provided schedule. So we should be able to trace through that information in that way. And then there's also some information on, days of operation, dual certification status, and if your site operates as another, entity type, such as a clinic or an FQHC, or, some other type of designation. The second part of the cost report should be copied and pasted to an additional tab for each additional site that falls under the CCBHC. So CCBHCs may have multiple locations, but it'll receive the same PPS rate regardless of location. So in this example, I've copied part 2 and pasted it to this second tab. And in this case, I have the second location that is, duly certified as a CC or as an FQHC in this example. So that's something we see sometimes. I know that, maybe sometimes behavioral health homes will duly certify, or clinics, as I mentioned earlier. But all that information is captured for each additional clinic. So if you have 4 clinics, you should have 4 provider information schedules. If you only have 1, you only need the 1. All right, so next we're going to move into the cost portion. So I'd like to start from a supplemental schedule. So you won't see this in the cost report. This is a sample working trial balance. And what I've done here is I have collected my data from a general ledger, and it's got the account descriptions, the amounts. And what I'm going to do is use the cost report lines from the trial balance to identify how to bucket my costs. So I'm going to assign the costs from the general ledger into specific areas of the cost report. And there's kind of 2 ways you can approach this at first. What you could do is you could place each general ledger category into a general bucket. And what that means is, you could classify the costs. For example, accrued PPS salaries, you could list that cost as a direct CCBHC cost. For accrued non-CCBHC salaries, you would list that as a non-CCBHC direct cost. And then for administrative staff salaries, you could list that as administrative or indirect costs. So that's a way that you could start to bucket. The method that I'm showing uses specific lines on the cost report to assign to each working trial balance line. So I know that all PPS salaries will be included in part 1 of the trial balance, part 1A, which is the direct staff salaries. So that'll be lines 1 through 17. Or for example, accrued non-CCBH salaries, that relates to line 51A in the trial balance. You can tie administrative staff salaries to line 40, which is classified as office staff in the trial balance. So you'll see all of these lines and become more familiar with each additional line as we walk through the trial balance. But I just wanted to give you some context on ways that you can look at your working trial balance and start to group costs together. Reminder again, that all expenses on that working trial balance need to be reported in lines 1 and 2. So even these non-CCBHC costs, these are excluded from the PPS rate, but they still need to be reported in the non-CCBHC cost portion of the cost report so that we can validate that it ties to the audited financial statements. Okay, this is kind of a supplemental analysis as well of salaries. So what's going on here is that I've taken my salary information from the services provided or from the working trial balance and taken my staff from services provided, those FTE counts, and then assigned wages based on the position. You could go through, your payroll data, for example, and be able to tie that out. So that is a way that I would recommend approaching, if you have accrued PPS salaries as a general ledger line, or, like provider salaries, or, CCBHC staff salaries as a general ledger line. I would recommend preparing an additional analysis where you show how these costs are broken out. Again, it's helpful for preparing the cost report. It's helpful for the state and for its reviewers in understanding the way the cost report was prepared. One other benefit of this is that I can look at certain costs that may need to be reclassified because there are certain shared resources. So in this example, you as an organization or as the CCBHC will have the greatest insight into what services and what activities are performed by each individual. So let's say, for example, that all of the psychiatrists perform a certain portion of their time in administrative functions. In that case, I would need to make a reclassification of a portion of their salary from direct CCBHC costs to indirect costs. So I'll reclassify that cost to office salary. So that's an example of how using a salary support schedule can help develop, from the general ledger into the trial balance. I might also recommend this if you have anticipated salary costs. I do think that it's always helpful for me as a reviewer to understand the reason for the allocations, additional FTE for any anticipated staff costs, and then tying that through to services. So make sure, again, the key point of pretty much all of this is just document all the assumptions well. That is the best advice that I can provide. All right, so let's trace this through to the trial balance. So using my working trial balance and the salary support schedule, I have everything I need to transcribe those costs from my financial reporting data into the trial balance. So at this point, let's walk. I actually see that we have a question in the chat. How long do you estimate that it will take to reconstruct our organization's financial data to prepare the cost report? That is a great question, and I don't prepare cost reports, so I don't have much insight into the length of time that it would take. I can only tell you the strategies that will be used. But I have seen organizations prepare their cost reports. I would say generally about a month of work. Again, I don't have insight into the exact hour breakdown, and it depends on the complexity of the organization, how well the financial reporting system captures the costs, and some other, criteria such as the tenure of the staff, the financial reporting staff. But I think that, budgeting at least a month to complete the cost report is a good strategy. All right, moving on through the cost report, I'm going to start in part 1A. So we're just going to start at the top. You might remember that this is the direct CCBHC staff costs. So all of these costs are going to be fully included in the PPS rate. These amounts in columns 1 and 2 should tie through to my audited financial statements when summed in column 3. So these figures should directly tie back to the working trial balance and ultimately the total expenses in the audited financial statements. All right, after line 3, we use the reclassifications and adjustments columns to, work with the costs and reallocate them and make those necessary adjustments in order to accurately capture the CCBHC's costs. So the example that we just walked through with the physicians that perform some administrative functions, you can see that if I go back to my working trial balance salary support, I should make a reclassification for this, $798,000 amount from line 1 to line 40 because of the administrative time spent. So I've made the reclassification on line 1 in a negative amount. Remember, each reclassification gets an equal and opposite reclassification to another line. So I make the negative reclassification to move the costs to line 40, which is the office salaries. So you can see there, line 40, that's where I've re-bucketed those costs. So the financial reporting system captures data in one way, But to accurately reflect the CCBHC costs, some reclassifications and adjustments are needed. All right. Moving through the cost report, you can see I've got an adjustment in part 1 as well. This adjustment is for some grant funding. So without knowing the allocations that I've made, these numbers are just numbers. Rest assured, I have documented my allocations and reclassifications in the allocation descriptions tab. So you'll see the exact math behind this number in a minute when we get to that schedule. Just know that for now, I'm removing some grant funding that covers CCBHC services. Again, I want to avoid duplicative payment, so the PPS rate can't cover what grants will be covering. Those costs shouldn't be double covered. All right, moving on to column 8, you'll see some anticipated costs. Anticipated costs, as we mentioned, may be for an expansion of staff, maybe for an expansion of services or the amount or type of services provided, or even necessary changes to the CCBHC's structure or system to provide the full array of CCBHC services. And what I mean by that last point is, there may need to be some changes in administration, or like you may need to hire an additional accountant to work on cost reports. You may need to make some changes to the EHR. So those expenses can be recorded in anticipated costs, so long as there's sufficient justification. So in this example, you'll see some anticipated costs, which will be for staff. So this CCBHC, for example, will need some licensed mental health counselors to be able to provide the full array of CCBHC services. So in this example, this amount is needed, and I'll show you the FTE counts that support that in a minute. I saw maybe we have another question. Is column 8 where you would want to reflect increases in compensation that have occurred since the last audited fiscal year? I don't think that that's the case. I think, column 8 should be reserved for the costs that are needed to move from, the current clinic structure to being a CCBHC. What this question may be referencing is, if there are additional costs that have been incurred since the audited financial statement period, and the present day when the cost reports are being prepared, those costs would be reflected as positive adjustments in column 6. So if I had, hired an additional psychiatrist, for example, I would record that cost as an adjustment to column 6, because it may not be, accurately captured if it happened after the audited financial statements were released. So I think that is probably what the question was getting at. All right. So we've covered part 1A, that's direct CCBHC staff costs. Moving through, you can see some DCO costs. So again, these DCO costs are based on the actual costs that are reported by the DCO. So the costs that are reported by the CCBHC for DCO are not the costs to compensate the DCO for providing the service. It is the cost that the DCO incurs for providing the service. So that's an important distinction to make. And then you'll see some adjustments and anticipated costs for DCO, which is typical. You'll see the allocation later for this adjustment, but I can tell you now, this adjustment is made based on a related party transaction. So if there's any gain on related party transactions, there would need to be an adjustment to market. So that's what's happening in this case. And then you can also anticipate costs for increase in DCO services as well. All right, I'm going to finish this part of the cost report. We'll keep moving through the trial balance, and I'll get to this next question that came up in the chat after that. All right, so additional costs, part 1C of the trial balance captures other direct costs such as supplies, healthcare staff, transportation, telehealth, professional liability insurance, and so on. So I think that this is all pretty straightforward and aligns with what we've walked through so far. But just note that there may need to be some reclassifications here, as you know, professional liability insurance or telehealth, for example, those services may also be provided for non-CCBHC services. So make sure that those providers, those costs are properly allocated between CCBHC and non-CCBHC. All right, indirect costs flow through two categories. Part 2A is for site. So that will be, you know, rent, insurance, facilities, things like that. So make sure that those are all, you know, expenses that are properly reported. And again, I think this is pretty straightforward. Part 2B is the kind of personnel and professional services portion of the indirect costs. So you'll see legal, accounting, insurance, and other similar costs, office salaries in this portion as well. But it's very similar to the portion above, just different line items included. Again, make sure any necessary reclassifications are made, and you will see, I will say, in the indirect cost area is where I personally see the majority of adjustments needing to be made. So while you'll see grants being offset in that part 1, those direct costs, what you'll see in part 2B is maybe, you know, bad debt expense may be captured as an indirect cost, or there may be some lobbying costs that are captured, maybe some most advertising and marketing costs are also unallowable. Again, reference the CFR 45 part 75, especially subpart E, for guidance on specific items of cost. But be very careful when preparing the indirect costs. All right. Finally, line 51A. Really, lines 50 and lines 51A are important here, but direct non-CCBHC services can be reported in line 50. I've actually classified that as line 51A here. Regardless, it won't affect the PPS calculation. So just know that all your costs other than CCBHC and indirect costs, all your costs for other services are reported in this part 3. All right, and then I also want to call out this specific line, line 53, column 3. This is the number that will tie to the audited financial statements. So, you know, I would probably recommend preparing lines 1 and 2 first, and then taking a look at this column 3, line 53, and comparing that to the audited financial statement expenses. At that point, you know, it should tie out. If it doesn't, I would rectify that before moving on with the rest of the cost report. So something to be conscious about. I'll also call out column 4, line 53, column 4. Note that my total reclassifications is 0. The reason for that, again, is that all reclassifications have a positive component and a negative component. I'm moving costs between lines. Now the adjustments are different. So that is for the complete addition or complete removal of certain items of cost. For example, I may remove some unallowable costs. In that case, they would be wholly removed. All right. So now that we've walked through the trial balance, let's answer these questions and then move on to the supporting schedules. All right. In the original invitation, we were provided these templates. When would we get the most updated or revised document, including the working trial balance tab? All right, so one thing I want to reiterate before answering the rest of that question is that the working trial balance tab is an example of a supplemental schedule. So you would probably produce your own working trial balance tab using your general ledger and that financial reporting data for the reporting period. And then, creating certain formulas to bucket those costs and, doing some manual identification of where those costs belong in the trial balance. So when you look through the cost report template, you won't see the working trial balance salary support schedule or the working trial balance or this monthly enumeration schedule. So those will all be examples of supporting documentation that you use outside of the trial balance to prepare your cost report. And you should submit those basically work papers, right, to the state as a part of the required documentation to support the cost report. So I hope that helps. Does the cost report establish a cap on service delivery, both in terms of staffing levels and encounters, or does it just establish a PPS rate that gets applied if a service delivery exceeds the cost report data? Okay, I might call on you here, John, and see if you've got some input.
Yeah, it's the latter. It just establishes a PPS rate that gets applied, and then that rate gets applied to any number of qualifying monthly visits beyond what may have been utilized to sort of devise the rate, from the reporting year. I believe that's what the question is getting at.
Okay, all right, thanks, John. How should directors who supervise direct care staff be treated? All direct. That's a good question as well. And I believe in this case, the supervision of other direct care staff would that be an administrative function, John, or would that fall under direct costs as well? I would also like to see if you've got input on this one.
I think I'd like Mike to weigh in on this, actually. Yeah, from a CPA perspective.
All right, Mike, do you have any?
Mike.
Sorry, go ahead.
Okay, I was going to say, my thought is managers or supervisors of direct care staff are there to support the direct care function. And that is what I thought when this came up. Okay. But if that direct care staff is only directing, because they're required to be supervised, if that supervisory function of a direct care staff is only half of their time, then the other half would go to indirect. But that's what I believe. Okay, so I think that makes sense, and that aligns with what I was initially thinking. So we may have to do some additional looking into this, but at this point I think that it's fair to assume that supervision of direct care staff is a supporting service of direct care provision and can be treated as a direct cost. I think that it's also important to note that there may need to be allocations made for supervision of non-CCBHC direct care staff. So there would need to be an allocation made based on who the director supervises and which specific activities they're supervising. So that's something to be aware of while you're doing this allocation. But I do agree that it would be a supporting service of a direct care service and could be treated as such. All right, keep those questions coming in the chat. I think that we're starting to come across some really interesting topics, so feel free to keep those coming, and we'll start walking through the supporting schedules of the trial balance. So here's an example of the trial balance reclassification schedule. What I want to point out is that you should fill out the trial balance reclassification schedule and the trial balance. A lot of the times we'll see maybe reclassifications will be made in the trial balance, but the reclassification schedule won't be filled out, or vice versa. To be able to accept the cost report, we need to have both tabs be complete. Now, the information should be accurately reflected between the two tabs. So we should see the reclassification being made for $798,000 out of line 1. So there's my decrease. Again, this is related to direct care staff providing some administrative functions. And then there will be an increase in line 40. So
those are the two reclassifications that I've made. So in the trial balance, I should see no further reclassifications. And I should see the amount of 798,000 as a positive reclassification in line 40 and as a negative reclassification in line 1. So I'll check the trial balance. I tie out to 0. I can see that these amounts are equal, so that makes sense. And then I'll look through the reclassifications. I see a positive $798,000 in line 40, so that is correct. I do not see any other reclassifications except for the negative reclassification from line 1. So in this case, I recorded all of the reclassifications from the trial balance in the trial balance reclassification supporting schedule. Now you may notice that these amounts are broken out into 2 different items. And the reason for that is, even though they impact the same line, they are for different general cost pools, or general like lines of cost. So a portion of that reclassification is for medical doctor's salary. And then the second part of that reclassification is for medical doctor benefits. So I think that is a pretty comprehensive and thorough way to document exactly what is happening on that line. Again, there's actually going to be a third place, and I think I'd like to show that now, where those costs should be recorded. So we should be able to verify throughout all the schedules of the cost report exactly what's happening. So I'll show you now. This is the allocation description schedule, and this schedule is going to reflect any allocations that I've made. Again, supporting documentation may also contain allocation descriptions, but I would like to encourage all of you to record any allocations that you make in your supplemental documentation in this schedule as well. So I can see my first bullet point, a reclassification of $798,000 was made to line 1 of the trial balance related to salary and benefit of MDs. Time is split 60% direct for services and 40% for indirect. This is based on a time setting. Again, remember, any allocations I make need to be based on something I can reference, such as a time steady or percent of services. And they're based on that percentage and consistently applied to both salary and benefits. So that amount that's reclassified represents 40% of both the psychiatrist compensation and other, which would include the benefits. So that is the reason for that specific amount of reclassification. All right, moving through to the trial balance adjustments. I've got a couple different items here. So let's walk through a couple different, transactions that would need adjustments. The first one I already explained a little bit, but it is a related party expenditure above cost. So again, that one relates to line 19, which was the DCO. So if the DCO expenditure was greater than the cost, the amount over cost would be removed from the cost report. Here's 3 grant funding examples. Or 2 grant funding examples, sorry. The first grant funding example is an example of grant funding expected to continue throughout the demonstration period that should not be included in the PPS rate. So this is grant funding for a CCBHC grant. And so that entire $100,000 is removed from the cost report since that grant supports only CCBHC services. Here's a portion of a grant that supports both CCBHC related expenses and non-CCBHC related expenses. So this grant can be used for either CCBHC or non-CCBHC. So the way I'm going to allocate the part that needs to be removed is based on a percent of services. So in the allocation description schedule, the adjustment, I actually should have documented that, I'm sorry. But in the trial balance, I can see I made the adjustment for $179,300. In the allocation description schedule, I would say that that amount, that 79,300, is related to a general grant or, you know, a behavioral health grant, something like that, that can be used for both CCBHC and non-CCBHC services. And so that description occurs in this line, 11B. Okay, for fundraising costs, remember these are my unallowable costs. So any of these items that appear in my general ledger, I will need to remove from the cost report. So fundraising is unallowable. So let's say I had an office entertainment expense, maybe I held an office fundraiser, and that amount appeared in line 42, which if I go to the trial balance will cover office supplies, line 42. So I'll make an adjustment related to the specific amount that those costs would have been for that event. So sometimes you'll need to use an allocation like we saw in the grants, and then sometimes you can trace specific costs. Another example of this is advertising and recruiting. So let's say I incurred $12,000 of advertising costs for the year. Those costs are unallowable and need to be removed from the cost report per CMS cost reporting principles and the CFR Part 75. So advertising and marketing costs generally are unallowable, and I will remove those costs from my cost report so that they don't impact, you know, they aren't paid out through CMS and through Medicaid in part of the PPS rate. Okay, and I've made allocations for these expenses or for these adjustments as well. So you can see I've documented the related party expenses. I've documented the office company supply expense, and I've documented general advertising and recruiting expenses that should be excluded. So providing a really solid description and an account of the amount that has been excluded or adjusted out is a great way both for yourself and again for the state and its reviewers to understand you know, exactly what transactions underlying the cost report need to be adjusted. All right, let's walk through an indirect cost allocation example. So now that we're done adjusting our costs and making the reclassifications needed, we need to come up with a way to allocate the indirect costs. So the totality of CCBHC direct costs go into the PPS rate, but only a portion of the indirect costs go into the PPS rate. This first example I'll show you is an example of using what we usually call the direct method of allocating indirect costs. So you can see there's a couple questions that you'll have to mark yes or no. So these are the examples we walked through of cost allocation. So is there an indirect cost rate that it is approved by a cognizant agency? So I've marked no. We'll walk through that example next. Does the CCBHC qualify to use the federal minimum rate and elect to use the rate? I've marked no. Will the CCBHC allocate indirect costs proportionally to the percentage of direct costs for CCBHC services versus total allowable costs less indirect costs? So I've marked yes. So this is the direct method. So all I have to do is mark yes or no if I'm using one of these methods. If I'm using the cognizant rate agreement, you'll have to enter in some additional information. But if I mark yes on line 11, all the math is done automatically. And I'll show you how the math works right now. So line 29 of the trial balance captures direct services for CCBHC costs. Line 52 of the trial balance captures non-CCBHC direct costs. So by adding line 52 of the trial balance plus line 29 of the trial balance, I can get the total direct service cost. Then by dividing line 29, so that is just the CCBHC direct costs, by the total direct service costs, which includes some non-CCBHC direct costs, I can get the PPS direct service cost percentage. So you'll see my 87.3% that I've calculated ties out to the amount calculated by the formula. Then the total indirect cost as reported on the trial balance line 49 is multiplied by the PPS direct service cost percentage, which gives you the indirect cost in the rate. So you can see this amount, this 9 million amount, will tie out to line 16. So that's how the math works. It just multiplies those indirect costs, the total indirect cost, times the ratio of CCBHC direct services to total direct services. And then I've calculated the allowable amount by adding this, $9.1 million of indirect costs to the $23 million of direct CCBHC costs. So you'll be able to tie this figure out to the PPS2 schedule. Let's review a cognizant rate agreement example of indirect cost allocation. So, use the documentation that you have from the cognizant rate agreement. Again, you'll need to submit that as part of your reporting package with the cost report. So you'll select yes for item 1, enter the basis amount subject to the rate agreement. So that'll be my indirect costs, and then enter the approved amount. So that is the rate that you'll use from the cognizant agency. So in this case, just a random example, my rate is 26.5%. So how this method works is you just take the indirect rate agreement rate times the PPS direct costs, which will give you the indirect costs. And that gives you, when you add the indirect plus the PPS direct, you will get the total allowable costs. So you can see there is some difference in the total allowable cost between the cognizant method and the direct method that I showed you in the last example. But just remember that if you have a cognizant rate agreement, you must use that agreement. Otherwise, you can elect, the federal minimum rate or, the direct method. All right, we've talked through allocation descriptions. Let's look at anticipated costs. This schedule pretty accurately reflects the trial balance in the way that it has the lines of the trial balance. Again, this schedule does not automatically populate to the trial balance. So it's like the reclassifications and adjustments supporting schedules where you need to enter your anticipated costs on this schedule and then transpose those costs to the trial balance line 8 or column 8. So you'll be looking at column 8 and copy the costs from anticipated costs to the trial balance. Again, make sure the documentation is very thorough for all anticipated costs. Make sure that any direct anticipated costs correspond with anticipated visits, and then make sure those amounts are reasonable and can be supported by your organization as you pursue CCBHC certification. So on this schedule, you can also enter additional FTE counts, which is very helpful for us to consider, how the staff are being compensated and how the additional staff relate to additional monthly visits. So again, those components are all going to tie together. So make sure that you document those really well. But you can see there's some addition of staff in this example, as well as additional DCO costs, additional supplies, because the staff will need supplies to support the performance of services. And then additional indirect costs as well, because, there will be additional maybe rent. Maybe I'll need to rent a new site because I'm planning to, expand my staffing and the services. All right. All right, so let's move on to the comment schedule. This schedule you can just use to write any additional comments, any additional, allocations or assumptions that you made in preparing the cost report. You should document on this schedule. So in this case, I've included anticipated direct cost. So if I have new hires, I'll have anticipated costs. Hired to perform CCBHC services, that is a comment that relates to the hiring of these anticipated costs. Again, the schedule kind of just helps, tie all the cost report together. But if you're supporting, thorough supporting documentation as well, any assumptions or directions to that supporting documentation can be made here as well. So if you have, you know, a monthly visit schedule, supporting schedule, where you enumerate your monthly visits and you included anticipated visits, maybe you would include a comment in this comment schedule that says, all right, like, here's the methodology that was used to determine anticipated visits. And here is the tab in the supporting Excel file that you can see how that number was developed. So this schedule can both tie the trial balance together and tie the supplemental documentation that you submit to the trial balance. So there's a couple different uses for this schedule, but ultimately anything that helps the state and, you know, yourself and the reviewers understand the cost report better should be documented in the comments. All right, we've walked through the monthly visit schedule already. So I think we're okay there. Here's another, this is a different example that just includes some DCO costs. So you'll be able to see how DCOs are recorded. And then there's some anticipated costs as well, but we've already walked through this at length. So I hope you all have a pretty good understanding of, you know, what each row and column is doing. At this point, though, we'll move to the end of the cost report, where we will take a look at the PPS2 rate. All right, so costs, I'll zoom in a little, I'm sorry, my screen is a little small, but you'll report actual charges. Again, that will be the actual charges from the CCBHC on line 1. So that will be for the reporting period, what were the charges for the standard population? And you'll record that amount in line 1. Now you'll also have the charges above the outlier threshold. That'll be reported in part 1B. And again, that will be for the reporting period. What is the dollar amount of charges for claims that exceeded the outlier threshold? You'll report anticipated additional charges as well. So, you know, in the next cycle, what do you expect to incur on top of what you incurred historically? What is the expected additional charges that you anticipate? So in that case, I've, you know, drafted some figures based on assumptions of visit increases and capacity increases, and maybe even expansion of services. What charges can be expected in the following period? Now you'll see at this point, the charges are allocated based on the cost to charge ratio. So the total amount of allowable CCBHC costs will be allocated based on the cost to charge ratio between the outlier threshold and the standard population. But you'll see that that sums to total allowable CCBHC costs. So that's how we tie out the trial balance to this schedule. From this point, the standard population costs that have been allocated based on that cost to charge ratio are divided by total monthly patients, which includes DCO and anticipated patient visits. That'll give you the cost per visit. So in this case, $647 per visit. And then the MEI figure is used to trend that allowable cost per visit to the final PPS2 rate. So in this case, the $647 amount times 6.71, that'll be the percent increase, gives you $690 per visit. And that is my final PPS2 rate for the standard population. You'll see that the remainder that was allocated for those costs that were above the outlier threshold goes to what is called the outlier pool. And that figure is, you know, added to the general outlier pool for CCBHCs and paid out in the future by the state. All right, quick review of MEI calculation. Again, you find the index for the rate period, or for the reporting period. You find the index amount for the rate period, and then you'll divide the indexed rate period by the indexed reporting period. So you get the midpoint of the reporting period and the rate period, and find the corresponding indexed amount from that market basket. So if my reporting period in this case is July 1st, 2021 to June 30, that should be June 30th, sorry, but June 30th, 2022, the midpoint is going to be the fourth quarter of 2021. So you just go to, you know, the exact midpoint of that year, and whichever quarter that falls in will be the midpoint. So that is how you find the indexed amount that is appropriate for the MEI calculation. But again, all you need to enter in the PPS2 schedule is the charges, and then the MEI, and the rest of the rate is calculated. So at that point, we've wrapped up our review of the CCBHC cost report. We walked through some supplemental schedules that you can use, like the working trial balance and visit enumeration. And I think what I want to end on here is just, I cannot emphasize enough that you should make sure that all your assumptions, all your calculations, and all your allocations are just really thoroughly documented. I think that that is the recipe for success in preparing your cost report and helping the state and set up this whole CCBHC demonstration and get the rates approved at the state level. So I wish you all luck as you go forward and prepare your cost reports. I'll open the floor to more questions. At this point, we can take some live. We've still got 10 minutes on the schedule. And I do see a question has come through the chat. So you mentioned that a client who has a billable encounter with the CCBHC and a DCO counts as only one encounter with the CCBHC, then paying the DCO for its service per contract. What if a client has billable encounters with numerous CCBHCs? This is a really good question. And I think I'd like to pass this one over to John to see if he has any thoughts on how to approach this specific situation.
I think we may want to take this one back to discuss it, just because this is complex, and it requires, I think, some state systems also to kind of do like a retrospective review of utilization. This is not indifferent to FQHCs, where a given person could go, you know, to multiple FQHCs on one day and technically trigger multiple PPS payments as a result. And I just want to discuss this with the state folks to see how they track that, and if that could be applied, you know, in the context of the CCBHC. So I think I'd like to defer that question.
Okay, great. Well, we will follow up with an answer for that.
I can say that it depends on the service that the person is receiving. As we will establish a relationship with a Trezzo, as all the providers here should be familiar with what that system is, and registering services within CCBHC, there will be some support for duplication tracking, dependent on the service itself that the person is receiving. However, receiving that service from a CCBHC and receiving a different and separate service from a CCBHC would not prevent the separate CCBHCs from receiving their PPS payments. Meaning if someone gets med management from one agency and case management from another, those two services would be PPS generating for the separate and distinct CCBHCs. I do think a written response on this can be really helpful because it is complicated, but we are working on the system to be able to support that access to care, because it really is about that. It's about people being able to access the care where they need it and who they have relationships with.
All right. Thank you, Liz. We have another question about, can you describe how the outlier pool will be allocated? So each CCBHC's outlier pool kind of goes into like a state outlier pool, which will be paid out to CCBHCs at a later date. Some states have chosen to reimburse a portion of the outlier pool for claims above the outlier threshold. So I believe that was something that New Jersey had pursued, where I think it was like 80% of the amount above the outlier threshold was paid out. But it's kind of just acts as a reserve to be paid out, if my understanding is correct. Although I will call on Mike to see if you have any other context to add to that question.
No, you covered it, Toby. It is a pool that's held back and then paid based on how the state determines to pay it. If it's a percentage above the threshold, and then with the true up at the end, it is kind of discretionary, but it is a withhold that gets paid out to those above that threshold.
Okay. All right. Thanks, Mike. All right. What services will be allowed concurrently that are included within CCBHCs as this impacts our projected encounter rates? I'll pass this one off to Liz. Do you have any thoughts on this?
Yeah.
All right.
For any provider that is utilizing the encounter requirements document that was attached to the invitation, we will be sending out kind of clarified and revised versions as we get feedback on those in the next day or so. But the PDF encounters, EBPs, staffing requirements document references sections of policy that that either the definition was derived from or that the definition of that encounter is directly related to. I would follow the I can't remember in policy what we call it either. It's duplication or non-concurrent, delivery of those services for those encounters as it relates to your CCBHC. So for example, and med management within section 65, if there's any duplication that's already identified for that, you would follow those rules for the med management within CCBHC.
All right. Thanks, Liz. All right. We've got 5 minutes left. So if there are any more questions that are just burning in your mind, please feel free to come off chat or come off mute or put them in the chat.
Yeah, sorry, I answered it from so I'm replying right back to Dale on the concurrent or the Dale team. I think there's a team there, so I'll say community health and counseling. It would conversely apply, right? Like all the services that are not duplicative would be allowed to be concurrent. I think we did try to go down through the encounters document to also say, generally what the billing guidance would be for each encounter. So if you have specific questions, that could be helpful. Like on the actual encounters document, we can tackle them.
Liz, this is Mary Jane. I'm going to go off mute and ask more about that question. So if psychiatry is delivering psychiatry services, but the rest of the services are done through another CCBHC, does psychiatry then bill under section 65 because that patient is not one of their CCBHC clients?
No, not necessarily. If the person is if I'm understanding your question correctly, the person would receive, that would be a PPS generating encounter that you're providing that service as accounted for on your cost report, right? You accounted for that as a part of your PPS. So you would deliver that service as a part of your CCBHC. I think it goes back to how, oh, go ahead.
Yeah.
Sorry.
But what if there are two CCBHCs in the same region and other services are provided by the other CCBHC?
Right. Then the person would receive those services from that CCBHC. There has to be agreements between your two agencies on how to coordinate care and communicate care. That is an expectation that we've set as a part of your requirements for certification. So that there isn't going to be, that you can attest that there isn't duplication of services, but that you're providing the services that the person has requested from your agencies and that you're able to provide. Right, so you're accounting for the cost of services that you're providing for that person or the people that receive care from your agency. And then the other CCBHC is accounting for the cost for the services that they're providing to those patients as well. So they're not accounting for the psychiatry costs for the person that you're serving. They're accounting for psychiatry costs for their panel of people that they're serving. Okay. It gets back to the FQHC example. I love that example that John shares. that shared about how somebody can go to an FQHC within 2 different FQHCs and receive care. We have the same expectation for CCBHCs, that people can receive care from different CCBHCs because it's not a program. Instead, it's the model of your organization to provide services in a high quality way. I want to answer Josie's question real quick. Toby, is there anything that you want to wrap up? I also have a timeline I want to share before we close the meeting out today.
No, absolutely. Feel free.
Okay. Josie, it's a great point. I am going to send out an updated Excel spreadsheet and PDF document to the invitees on this calendar invite, and then we'll also be posting the recording, the PowerPoint, and any public materials to our rate reform website, and that will go out on a listserv. So if you aren't on the invite and you don't get that update from me, you'll also be able to get our main care listserv email with all these materials posted. So on the Excel spreadsheet, there's an asterisk next to behavioral health homes and opioid health homes as costs that you would account for on your cost report. Because I didn't separately tease out the codes and the elements that go into BHH and opioid health homes, you would account for the costs that you have for those services as a part of your CCBHC cost report. We are including those services as a part of CCBHC delivery. And so the asterisks they probably don't have like a reference anywhere else on the spreadsheet, but it was to note that those are kind of special services that you're not going to separately be billing BHH and OHH within your encounters document. You won't find them as encounters, but you will incorporate the costs in your cost report.
What will trigger OHH though, Liz? There's nothing else in here that references section 93.
What do you mean, what will trigger?
Well, I see what would be a triggering event for any OHH services. I see that BHH falls under, is referenced under CI, under, but I don't see OHH, no triggering events for OHH anywhere. Or with.
Yeah, let me take a look back at the encounters document to ensure that we do call out where section 93 is referenced for certain encounters. But I would say that it is a matching of the 2 documents, that the code list is meant just to be a supportive tool for your cost reporting. And then the encounters document is the definitions of the actual CCBHC services as we are moving forward and the alignment with current main care services. So let me go back and make sure that 93 is represented. Thanks, Josie.
You know.
All right, any other questions that we want to ask out loud or put in the chat before I share some wrap up? Okay, great. Okay, so thank you all for sitting through the training today. I think it was really valuable to hear from Mercer, to be able to have a space for you to ask questions and share questions as they're coming up. Looking at the cost report, thinking about the services that you provide, that you want to provide, that your community needs. And what I'd like to share is the timeline and our expectations over the next several months for our partners in this work together. Okay, so as we shared in our September 25th stakeholder meeting, we are pursuing the Prospective Payment System 2, the monthly PPS. You just received the cost report training today on how to complete the cost report. And we have some provider technical assistance sessions coming up, as well as the Mercer team is available to answer questions via email. You can reach out to the state CCBHC inbox throughout this month. If you're an interested provider who wants to participate in the demonstration with us and be considered to participate in the demonstration with us. So the December 1st timeline is the first timeline or the first deadline in our cost reporting timeline. And it is for organizations that have an interest in being considered for the demonstration. It is not necessarily for everybody. Not every organization who's on the call today needs to complete their cost report by December 1st. We have heard from some agencies who are interested in that, and we thank you for being vocal about it initially so we know who you are. If there are others who want to have some conversations with the department or with Mercer, don't hesitate to reach out to ask questions about that December 1st timeline or deadline. We will have a review of those cost reports through conversations with the providers, internal conversations, obviously, on the information, requesting more information throughout December, January, and February. And then we'll be sharing draft rates in February for the selected providers who are going to participate in the demonstration with us, and then working on finalizing those cost reports in the spring after we do our demonstration application. All of this is about our demonstration pursuits right now. There are going to be other opportunities as we move forward with our CCBHC implementation next year for future requests for cost reports for other providers who didn't participate in this first round with us. I would consider this first round as like the bumpy test run that we're going through. And so again, we're thankful for those who are interested in doing that with us, who are ready for that rodeo. Because it will be messy initially. We're going to be testing a lot of pieces that we haven't yet implemented before at the department. And so this is an exciting time for us. But it's not the last time. It is just the first step in our process of getting to CCBHC implementation. We will be working on our state processes for CCBHC implementation, considering a state plan amendment, putting that through. And a part of that process, we will then request cost reports from interested providers for their certification, releasing certification timelines for those providers who are interested in that process. So stay tuned for that information coming forward. This was just a first run on giving you the information about the cost report. And again, don't hesitate to reach out to us if you are one of those interested providers who would like to be asking us any questions prior to that December 1st timeline deadline. So I don't know, I keep saying timeline deadline. Okay, that is all I wanted to share today. As far as the next steps in this process, I will put our email in the chat, and then you'll be receiving several emails from myself as well as the through the main care listserv with the recording and the PowerPoint. Great. Thank you, everybody.
Thank you. Very helpful.